maybe with an example or a video. Okay. So look at this. This is a patient who has come to you with focal seizure with secondary realization. And actually the patient looks like me because it's me. Because ethically and technically it's very difficult to record the patient's life. Ethical issues come in, and in case a patient of seizure comes to me in the OPD through seizure or emergency, what should I do? Treat or record? Treat, not record. I can't make an history of the things. So, and what context, in case the patient doesn't have the booking description, I cannot come. So this time the seizure starts in the right upper limb, goes to the right face, right side of the body, and then the entire body. So the seizure that starts in a limb focal and becomes all over is known as secondary realization. And what is the reason for this? Around the discrete region there is a lot of severity. That's the main reason for this. Okay? But please remember, in the life of focal seizure there are two more things to happen. One is Torts palsy, otherwise dystonia. What is this? If you read the word palsy, it basically means weakness or paralysis. So in my patient, after the seizure there is weakness or paralysis that happens. That is the most important thing after seizure post-ictal. So limb attack seizure becomes weak, now is known as post-ictal weakness or paralysis, not palsy. Don't worry about it, it is self-recoverable. With time to recover on its own. Well, another thing and the concept of seizure that is focal we have is Dixonian march. Okay, let's understand Dixonian march to a video better. So this time the seizure happens in me again. And when the seizure starts, it starts in the fingers and then the shoulder. Or it may start in the... So follow this again. So if I make an Insta reel out of it, you might think I'm doing a boomerang video, or maybe I'm doing a dance movement which was breakdance. And pioneer in breakdance was Michael Jackson. Jacksonian march. So in Jacksonian march, a focal seizure, what is the exclusivity? The seizure will start in the limb that is hand distal, and then it might go to the limb proximal, or it could be the other way around. Now please do remember this concept. The Jacksonian march and Torts palsy as two events will occur in patients of focal seizure only, not in patients of generalized seizure. So patients of generalized seizure will not have it, only the patients of focal seizure will get it. Okay, let's understand this topic with MCQ. You have just admitted a young man with a past history of seizure disorder who has just witnessed to have focal seizure. Now the focal seizure involves the left arm of the body as per the family description. The patient doesn't seem to lose consciousness. He was fully having impaired awareness during the episode. But the point of this is that why did he come to the hospital? He has come to the hospital because after 2 hours of the symptom onset that we had, in my patient, there is some kind of a weakness. Weakness in which the power in the left upper limb, which had the seizure, is 0/5. With the rest of the neurological examination, WNL within normal limb. Okay? And just on a safer side, we got an NCCT of the brain, non-contrast CT, to look out for any injury that is also WNL that stands for within normal limits. Now, what are we going to do? What is the best course of action? Let's understand this again. Here's a patient with me who seems to have a seizure on the left side of the body, that is left focal seizure. Now, after 2 hours of the local seizure, the left upper limb of the patient, the seizure variable, what is the best course of action? Let's understand this again. Here's a patient with me who seems to have a seizure on the left side of the body, that is left focal seizure. Now, after 2 hours of the local seizure, the left upper limb of the patient, the seizure variable, it was occurring, seems to have a power of nil, that is 0/5. So clinically, if I look at this patient, he is a patient of post-ictal paralysis, referred as what? Torts palsy. Torts palsy, non-contrast CT, to look out for any injury that is also WNL that stands for within normal limits. Now, what are we going to do? What is the best course of action? Let's understand this again. Here's a patient with me who seems to have a seizure on the left side of the body, that is left focal seizure. Now, after 2 hours of the local seizure, the left upper limb of the patient, the seizure wherever it was occurring, seems to have a power of nil, that is 0/5. So clinically, if I look at this patient, he is a patient of post-ictal paralysis, referred as what? Torts palsy. Torts palsy, the good part is that it is self-recoverable. It will recover on its own. So what are we going to do now? Reassess in few hours. Correct? So we know the answer, why it is an answer, but why not the other people? Why not the other people? Cerebral angiogram. This has been done to rule out something as a vascular abnormality in the vessel known as the aneurysm. I know aneurysms rupture to become what? Subarachnoid hemorrhage. First of all, this is not a history of subarachnoid hemorrhage. One. The CT scan doesn't show me a subarachnoid hemorrhage too. So I don't think that cerebral angiography is actually going to do any good for the patient. It's total waste of time and money both. Lumbar puncture, that is CSF analysis, is out of syllabus. Why? See, it's not a case of CNS infection. There's no fever, neck rigidity, autism, insomnia, anything of this sort. So lumbar puncture is again not a good thing. It's not going to take me anywhere because symptomatically the patient doesn't sound like a CNS infection. Someone doubted on this, sir. Told me, sir, why not psychiatric evaluation? And the people are not listening to him. So to gain attention, he starts doing a seizure after watching a video on YouTube. I said, okay, that means you're talking about pseudo seizure. Then I told the student, maybe you're telling about yourself. You're also a young man. Understand? Okay, anyway, pseudo seizure. Why not pseudo seizure? See, first of all, why will a patient of pseudo seizure come with a past history of seizure disorder? So technically we are out of that. Secondly, sometimes in our hospitals we find patients of seizure and pseudo seizure. And it's very difficult to let it know on the clinical basis that it is true seizure, not a pseudo seizure. Why? Because sometimes the motor movements in pseudo seizure are so perfect. After watching so many videos, they mimic actual seizure. Even a true seizure would have looked to me as a pseudo seizure. Kind of an OPD investigation. It's not immediately done. So there's another way. That is getting the patient hormone level done, that is prolactin. So this is a fact that we know that prolactin as a hormone is seen to increase in patients of true seizure and it generally stays normal in patients of pseudo seizure. And this prolactin that I know, yes, has to be done in my patient 20 minutes post-ictal. So after the seizure post-ictal, for half an hour if I check the patient's prolactin level, it will be found to be high. If it is a case of true seizure, not a pseudo seizure, where it stays normal. Okay. So, which hormone estimation is actually required for diagnosing a true seizure versus pseudo seizure? Prolactin. So, psychiatric evaluation is again now because it doesn't look to be clinically as pseudo seizure. Okay. Because he has a past history of seizure. So, any clinical vision, whenever you solve, please remember, you should solve it in such a way that you know the answer. You know why it is an answer, and most important, why not the other people? Because sometimes the question might change and the other people might become an answer. Right? But clinically, when I see a patient of seizure with a motor manifestation, how do they clinically come out right with a motor manifestation? The various kind of movement that we find generally in our patient. Let's try to see them one by one in a video. So in my patient, what will happen is that the limb that is right upper lip becomes stiff and stiff. If the stiffness increases in the limb like this, that means the increase of tone happens. This is what is referred as toning. Or maybe in the patient there is a continuous jerky movement that happens. So a continuous jerky movement is known as cloning, like this. Station. The various kind of movement that we find generally in our patient. Let's try to see them one by one in a video. So in my patient, what will happen is that the limb that is right upper lip becomes stiff and stiff. If the stiffness increases in the limb like this, that means the increase of tone happens. This is what is referred as toning. Or maybe in the patient there is a continuous jerky movement that happens. So a continuous jerky movement is known as cloning, like this. And third one is atonic. Imagine this, I want to keep my limb like this. In order to keep it there, I need to increase the muscle tone to keep the limb in a static posture there. But suddenly when the tone decreases, what will happen? My limb will fall. So there is a fall in the limb following the person due to loss of tone, referred as what? Atonic. And then myotonic. See, myotonus is something I believe physiological also. Like you are very tired and fatigued, and you're just trying to sleep, and someone wakes you up, or you are in a sleep and you see a dream in which you are falling down from a height. So then how do you wake up like this? So this is a myotonus that we have, a jerky movement which is not continuous but intermittent. So understand this, myotonic seizure is a jerky movement, but this movement is intermittent. Like this. While a clonic movement is a jerky movement again, but it is continuous. Okay, so finally let's write it down. A jerky movement, which I see, a kind of a movement jerky but continuous, is referred as clonic seizure. While a jerky movement, which is seen to be intermittent, is known as myoclonic. A movement in which the body tone increases is known as tonic. A movement in which the body tone decreases is referred as what? Atonic. And when the body tone decreases, the person sitting standing will just fall down. So if they are sitting, standing, doing something, you will just fall down. This has happened with me once, but not with me. I never had a tonic seizure. Don't imagine in the class and falling down. So I had a child who has come to our casualty almost 4th or 5th time from the morning assembly. And every time the teacher brought him and told us that he was standing in a queue for prayer, morning prayer, and suddenly he fell down. And every time everyone thought it's a case of a syncopal attack. And the child was slightly anemic also, so we thought it's all because of anemia, poor nutrition and all that. But something came into my mind. Why is he having recurrent falls? So I got his EEG done and that showed some kind of electrical activity here. So he was a case of what? Atonic seizure, because the presentation there is just history of fall. Okay. Now comes the probability of all the seizure. That is GTCs. Generalized tonic-clonic seizure. Also referred as the term given as grand. And I'm pretty sure this might have seen at least one patient in the hospital live having this term of grand mal epilepsy or GTCs. Let's see the patient again. At our end, what would have happened to the patient? Or I'll indicate better. So generally what happens is that a patient of GTCS when comes in the hospital, okay, they might give you some kind of a complaint, like some kind of a palpitation, abdominal pain, some kind of a vague complaint. And every time when they come and tell me this, I think something else. But suddenly the interface will start. So there is a complaint which happens in the patient prior to the seizure, where he comes and tells me that he is going to have a seizure. So look at this kind of a complaint. It's known as a premonitory symptom, a kind of a premonition that he comes to know that's going to happen. And then we have in the patient the interface, wherein the body tone increases. When the tone increases, we call this as a tonic seizure. Wherein in my patient, I would see the upper limb go into a stage of flexion and the lower limb stand in a stage of what? Extension. So imagine this. Anyone standing in front of you with the upper limb flexed and the lower limb extended, he seems to be in a posture which is referred as decorticate. In case upper limb and lower limb everything is extended, I would call this as what? Decerebrate. So today in my patient is a decorticate posturing or rigidity that is seen. Apart from this most interesting part, take a is going to change in hyponatremia, low sodium. Not complaint also. Giving them. Not complaint also. Okay, let's understand this topic through an MCQ. You have just admitted a young man, press the lung from outside. And then has a classical presentation. But why do we call this as epileptic? It is also referred as true seizure, not a pseudo seizure. The other way around. That is getting the patient. Or I'll indicate. They will be slightly confused. Today my patient is someone wakes you up, or you are in a sleep and you see a dream in which you are falling down from a height. Myoclonic seizure. So psychiatric vibration is again now because it increases the amount of fall down. So there is a fall in the limb, fall in the person due to loss of tone, referred as what? Atonic. And then myoclonic. See, myoclonus is something I believe physiological also. Like you are very tired and fatigued, and you're just trying to sleep, and someone wakes you up, or you are in a sleep and you see a dream in which you are falling down from a height. So then, how do you wake up like this? So this is a myoclonus that we have, a jerky movement which is not continuous but intermittent. So understand this: myoclonic seizure is a jerky movement, but this movement is intermittent. Look at this. While a clonic movement is a jerky it is continuous. Okay, so finally let's write it down. A jerky movement which I see, a kind of a movement jerky but continuous, is referred as clonic seizure, while a jerky movement which is seen to be intermittent is known as myoclonic. A movement in which the body tone increases is known as tonic. A movement in which the body tone decreases is referred as what? Atonic. And when the body tone decreases, the person sitting standing will just fall down. So if they're sitting, standing, doing something, they will just fall down. This has happened with me once, but not with me. I never had a tonic seizure. Don't imagine in a class of falling down. So I had a child who has come to our faculty almost 4th or 5th time from the morning assembly. And every time the teacher brought him and told us that he was standing in a queue for prayer, morning prayer, and slowly he fell down. And every time everyone thought it's a case of a syndrome attack. And the child was slightly anemic also, so we thought it's all because of anemia, poor nutrition and all that. But something came to my mind. Why is he having recurring falls? So that is easy done, and that showed some kind of electrical activity there. So he was a case of what? Atomic seizure, because the presentation there is just history of what. Okay. Now comes the probability of all the seizure. That is GTCs, generalized tonic-clonic seizure, also referred as a term given as grand mal epilepsy. Grand mal epilepsy. And I'm pretty sure this you might have seen at least one patient in the hospital live having this drama of grand mal epilepsy or GTCs. Let's see the patient again at our end. What would have happened to the patient? Well, I'll make it better. So, generally what happens is that a patient of GTCs when comes in the hospital, okay, they might give you some kind of a complaint, like some kind of a palpitation, abdominal pain, some kind of a vague complaint. And every time when they come and tell me this, I think so there is a complaint which happens in the patient prior to the seizure, where he comes and tells me that he is going to have a seizure. So look at this kind of a complaint. It's known as a premonitory symptom, a kind of a premonition that he comes to know that it's going to happen. And then we have in the patient the interface, wherein the body tone increases. When the tone increases, we call this as a tonic seizure. Wherein in my patient, I would see the upper limb go into a state of flexion and the lower limb stand in a state of what? Extension. So imagine this. Anyone standing in front of you with the upper limb flexed and the lower limb extended, he seems to be in a posture which is referred as decorticate. In case upper limb and lower limb everything is extended, I would call this as what? Decerebrate. So today in my patient is a decorticate posturing or rigidity that is seen. Apart from this most interesting part, the intercostal muscles that surround the lungs also show increase of force. That means they will compress the lung from outside. And then at the same time, the adductors that we have in the voice box of the larynx, the vocal proximal. I've got abductors and then adductors. So adductor or vocal proximal. So imagine this, on one end, the lung is getting compressed by the intercostal muscle from both the sides. And the air is coming out under force, and the outlet, that is the vocal cord, is approximated. Because today in the adductors, you seem to have what? Spasm. So on one end, the vocal cord is approximated, the larynx is closed, on the other end, you are squeezing the lung from outside. So what will happen? So air is coming out under force, and now it's coming out through a narrow orifice. So the person will have a loud cry and sound like this. That is known as an ictal cry. Okay? Apart from this, the air cannot come into the lung either, so the patient will have failure in those sinuses. Also in my patient, I will find increase of tone in the neck extensors. With the tone in the neck extensor rises the tonic phase, the head of the patient will come into one direction more often like this. So when the patient is shouting at the ictal cry, the head will also come like this. And then of course the person will be showing a continuous jerky movement. So getting shake more often. So a lot of froth will be negative, frothing will occur. Out of the two phases, please remember, tonic is shorter and the clonic is longer. Tonic comes first and then the clonic happens in this order. So tonic is there for a duration of 10 to 15 seconds. The clonic is there but it's for a duration of less than 1 minute. And then finally we have a post-acute phase, wherein the patient lies unconscious with a loose limb flacidity. And most important, the flacidity is not only in the body, it somewhere happens in the sphincters. Over the bladder, because of this, the urine in the bladder comes out with urinary incontinence. After the phase of convalescence recovers in my patient, they will be slightly confused, and then they will have headache. And they remember, the headache in these patients are seen to be what? In a way, transient. Not permanent. So I'll explain this again. So this type of patient has come to me in the hospital emergency with an acute pain in the abdomen. That's it. And when he comes with this pain, he comes and tells me, doctor, do something, I'll have seizure. I immediately tell the patient, Doctor, Google, this is cancer. Why are you telling me seizure? Google told you on the way. He said, no sir, Listen to me. Last time when I had Caesar, I had the same kind of abdominal pain. He's having premonition. 3 months. Listen to me. Look at the patient. He has got knowledge, but I have got ego. We all have got ego sometimes. So we don't match each other. So I did. Last night, where did you have food? Sir, I ate momos outside. Delhi sweet momos. Morning I had chola bhatura, night I had momos. I said, okay, this is because of the chola bhatura and momos. Today I am having acute abdominal pain. Colic. He said, yes sir, I saw you yesterday there at the dinner. You jump food because you're having fatty liver, you're trying to decide, having blah blah blah. When the food is finished, we both were standing outside McDonald's. Eventually. Anyway, so this time the patient comes with an acute abdominal pain, pre-market syndrome. Okay, that's the only complaint he did. So what do I give? I give a painkiller to the patient to replace the abdominal pain, and that is Tramadol. The moment I give Tramadol, what happens? The bomb explodes. The chronic phase starts with an active tempo, with a versific turn, and then the chronic phase happens. And then the post-ictal phase came, wherein the patient is unconscious. Classic. It's not a shadow of motion. It's an unconscious classic cause. Post-ictal. With urinary incontinence also, that I can show you the video. Anyway, looking at this video, one name comes to my mind. It has to be cut over and think. Yes, cut my please for this. So that's an episode of GBC's episode. So let's answer this. Which of the following is best explaining the cause of ictal cry, often heard in a generalized chronic fever? Pain experienced during the fever onset. No, it's not because of pain the patient is shouting. Is it? Sudden contraction of the abdominal muscle? No, it is due to sudden contraction of the intercostal, not the abdominal muscle. Laryngeal irritation caused by hypersalivation is causing ictal cry. No. Forced expiration against closed glottis due to chronic phase contraction. That's the correct answer. Okay. Now comes action sequence, another very important topic. Outside the books of pediatrics, if you read this topic, it is also referred as Petit-Mal epilepsy. Petit-Mal epilepsy. The petit as a French word means small, so doctors in small children. More often. Okay. And how does this actually present? The classical presentation is quite different. It's not motor movement and hormone, it's a totally different story. Like in my house, I play games with my kids also, because I've got 2 kids. That's why I've got 2 kids, I'm not a parent, I'm a referee. When my daughter plays a game with me, that is statue. Screen is safe, it's okay. You're not lost. But if someone tells me statue, I just freeze like this. The other person will make me laugh. By some gesture, particularly, I'm not going to laugh. I will not respond to the other person. At that moment, I will have a behavioral arrest. A stare over a blanket. Yes? So, at this moment, I am losing contact or awareness of the surrounding. If someone plays a mannequin channel or a statue game, that happens in a patient of absence seizure highly. They come to us with a behavioral arrest or a stare look, wherein the patient has loss of consciousness. And this loss of consciousness in the patient is for a very short duration, less than 30 seconds. And of course, on recovery, in the patient, there is eye blinking, lip smacking, and jerky movement of the hand. These movements happen on their own. They are known as automatism. Automatism is a generic word that we use for movements which happen on their own automatically. And what are these movements? Are they full-blown tony-cloning movement? No, they are very minor movements. Eye blinking, lip smacking, jerky movement. That is referred as subtle motor signs. Prior to the seizure, of course, there is no other. But how do you diagnose it? EEG, electroencephalogram. How do we do an EEG? Let's try to see this. On the skull, we are going to put electrodes that is going to map out the entire brain inside. So in theory, if I look at the brain, there's a frontal lobe head, this is the occipital lobe pole. In between, we have the central part also, the center of the brain. Now, if I put an electrode on the frontal region and I record over this a positive charge, while in the temporal lobe, I'm recording what? A negative charge. What does this mean? It means the lesion is there. Because this is positive, depolarization, this is negative, resting. So, EEG as an investigative modality is not only diagnosing a seizure problem. So, in theory, if I look at the brain, it's a frontal lobe.
We last did neurology in edition 6.5. So I think the subject for which I got the best feedback, or the most positive feedback, among all the chapters that we have done in edition 6.5, including my own subject that is neurology, among all the subjects that we have done, I think I got the best feedback for neurology. So I haven't done anything extra for that, but the best feedback that we did get was for neurology. Now, when I looked through the feedbacks that I got for neurology, primarily all the feedbacks were sent by MBBS students. Okay, they are not post interns. Everything is being sent by MBBS students. Even during my MBBS, and even now during your MBBS, we all have this feeling that the most important chapter inside entire MBBS. So during our MBBS, our feeling is that it is neurology. At the end of my MD course in Chennai, not just me, all our friends, when we asked me feedback about the course in general, the first feedback that we did give was the course is very lopsided in terms of so much importance being given to neurology. Like we have a feeling when we enter inside MBBS medicine, our postings in third, final, third, first, third, second, and also during second year, that neurology is the subject to study. Neurology is the subject to know. Without learning neurology, everything else is a waste. If you have to pass your MBBS, you have to present a case in neurology. You have no cases in neurology. You have to pass respect in neurology. So that I think is probably the reason that the videos were very well received. But on the contrary, what I personally felt by looking at the videos is that the videos were not short. The other chapters I tried to concise and do mentions going back, but I never had any kind of such a restriction in medicine in neuro. Primarily because the reason that I felt find the MBBS student, this is his chance to learn medicine. He's not being taught anything in the college level. He doesn't know how to examine patients. So with this and some of his clinical books and clinical discussions, he will be somehow able to get a feel of what is MBBS level medicine. So that's the reason why I took the liberty, I took the extra time. And you can actually see that 6.5 neurology is 22 hours. So 20 hours is a lot of time. 20 hours is a lot of time. So that's the reason I thought that that is there. That's about all the details. That's what I think in detail possible. We will do pretty much entrance oriented. So all the other chapters in edition 6.5 up to the core entrance oriented. If you ask me, neurology is also entrance oriented, but it's not just entrance. If you look at some of the modules that we have done through the evaluation of the arm, ECG is something that's not entrance oriented. It's more of a learning curve. Similarly, acid-based balance, hypertension, diabetes, slow. Welcome to the first of the proper points under neurology. So we can start with neurology from anywhere. We can start from the muscle and go back, which I tried in an animation. I tried starting with headache in one animation. But I think the best way to start off is by knowing who am I is very, very philosophical. Welcome to the first of the proper points under neurology. So we can start with neurology from anywhere. We can start from the muscle and go back, which I tried in an animation. I tried starting with headache in one animation. But I think the best way to start off is by knowing who am I is very, very philosophical kind of person. I'm not trying to fetch any philosophical answer for that, but as such in evolutionary terms, how we evolved as human beings and why we are what we are is basically because of our loops. And that's what we have to discuss in detail. Lower anatomy. In this first part of lower anatomy, we'll be looking at a very important lobe, that's the frontal lobe. And subsequently, we'll be seeing the temporal triangle and something called hospital is mostly to be identified after the So this is the first thing. Now, whenever I do a DM, the main problem with the DM course is we start digging deep into small things. That means we start studying anatomy for 20 hours, 24 hours, like that. So that kind of learning something to look at medium. So we have to study about animal models. Animal models are actually shown as this lot of studies. How many people are there and study what are the end of studies for. So as far as nephrology and something is concerned, all these studies are based on mice animal models. So they say that the human kidney and the mice kidney are exactly the same. There's no difference. So everything that is applicable to mice is applicable to human also. And I'm so glad to tell you that's absolutely not true in the case of the brain. The brain is evolved and evolved and evolved to a point where ours is the most beautiful brain, the most complex, the most evolved part, the most evolved kind of brain. You can never compare a human brain with any other animal under the sun. It is so much more complex, it is so much more evolved. And we're happy to be discussing this and happy to be knowing this. And that is essentially going to be about the master human brain. Now, the first thing that I want to tell you, that's why right at the beginning, this is the title that I actually gave to this module, but then now I changed. This is numbers to circuits. Now that is the biggest change in understanding, because when I was an MBBS student, we were all taught about this Brodmann area 4. Brodmann area 4 is motor, 312 is sensory. So now we understand this is not just one area, but it's about circuits, and those circuits are again what we are going to see. So starting off with the first of the major lobes, and that is the frontal lobe. Maybe student, please have the habit of writing case sheets, because case sheet writing will hold you in very good stead as you become an intern, as you become a PG. Everywhere it will hold you in good stead. I think the best part of our MBBS training was every day we had to write case sheets. Irrespective of whether the case is cirrhosis, we have to write CNS, RS, DIT, and of course CVS, and CNS again 1, 2, 3, 4, 5. We have to write everything and fill up the case sheet. So that writing became a practice. All of you please do that. So when you write the case sheet, the first part of your CNS is your higher mental function. This is what you write first. Okay, and that is exactly what we are going to study by lower anatomy and in an entrance oriented fashion. So whenever you write higher mental function, try to calculate the score called minimum mental status examination score, what we call as the MMSE score. And MMSE score is based on this ORR LC. I think everybody would have by hearted this, because this is what I write on the case sheet right up front. O stands for orientation, R stands for registration, A stands for attention, R stands for recall, L stands for language, and C stands for copying. This is what we test at an MBBS level, or even at a PG level. This is what we test in the patient. But again, lower anatomy is very important. Only knowing this, we can see, okay, this can be checked for, that can be checked for, and modification.
from the morning assembly. And every time the teacher got in and told her that she was standing in a queue in the hospital, like having this drama of grandma epilepsy or CTC. Let's see the patient again at our end. What would have happened to the patient? Or as we get better. So, generally what prediction, abdominal pain, some kind of a vague complaint. And every time when they come and tell me this, I think something else. But suddenly, the interface will start. So there is a complaint which happens in the patient prior to the season, where he comes and tells me that he is going to have a season. So look at this kind of a complaint, it's known as a premonitory symptom, a kind of a premonition that the customer is going to have. And then we have in the patient the interface, wherein the body tone increases. When the tone increases, we call this as a tonic season. Wherein in my patient, I would see the upper limb go into a state of flexion, and the lower limb stand in a state of what? Extension. So when anyone standing in front of you, the upper limb flexed and the lower limb extended, he seems to be in a posture which is referred as deep cake. It takes upper limb and lower limb, everything is extended. I would call this as what? Deep cerebrate. So today in my patient is a deep cortical posturing or rigidity that is seen. Apart from this most interesting part, the intercostal muscles that surround the lungs also show increase of force. That means they are going to compress the lung from outside. And then at the same time, the adductors that have the voice box of the larynx, the vocal cords, I've got abductors and then adductors. The adductors are going to proximate. So imagine this, on one end, the lung is getting compressed by the intercostal muscle from both the sides. And the air is coming out of the pores and the outlet and the vocal cords are proximated. Because today in the adductors, you seem to have what? Stop. So on one end the vocal cords are proximated, the larynx is closed, on the other end you are squeezing the lung from outside. So open it up. So air is coming out of the pores and now it's coming out through a narrow orifice. So the person will have a loud cry and sound like this. That is known as an ictal cry. Okay? Apart from this, the air cannot come into the adductors. It's an interesting part. The intercostal muscles that surround the lungs also show increase of force. I think they're going to compress the lung from outside. And then at the same time, the adductors that we have in the voice box of the larynx, the vocal cords, I've got abductors and then adductors. So adductors are going to proximate. So imagine this, on one end, the lung is getting compressed by the intercostal muscle from both the sides. And the air is coming out of the pores and the outlet and the vocal cords are proximated. Because today in the adductors, you seem to have what? Spasm. So on one end, the vocal cords are proximated, the larynx is closed, on the other end, you're squeezing the lung from outside. So what will happen? So air is coming out of the pores and now it's coming out through a narrow orifice. So the person will have a loud cry and sound like this. That is known as an ictal cry. Okay? Apart from this, the air cannot come into the lungs either. So the patient will become failure of sinuses. Also in my patient, I will find increase of tone in the neck extensors. If the tone in the neck extensors rises in the tonic phase, again the patient will turn into one direction more often like this. So when the patient is shouting at the ictal cry, it will also turn like this. And then of course the tonic phase. After the tonic, we have the tonic phase. Tonic phase is, the person will be showing a continuous everything. So this is a body shape with this feeling, this washing machine. So now the secretions from the lung are getting shaped more often. So a lot of froth will be generated, frothing will happen. After the two phases, please remember the tonic is shorter, the tonic is longer. Tonic comes first and then the tonic happens in this order. So tonic is there for a duration of 10 to 15 seconds. The tonic is there but it's for a duration of less than 1 minute. And then finally we have a post-natal phase, wherein the patient lies unconscious with a loose limb flaccidity. And most important, the flaccidity is not only in the body, it sometimes happens on the sphincters, over the bladder end. Because of this, the urine in the bladder comes out with urinary incontinence. After the phase of unconsciousness recovers in that patient, they will be slightly confused, and then they will have headache. And please remember, the headache in these patients are seen to be what? In a way, transient, not permanent. So I'll explain this again. So this time the patient has come to me in the hospital emergency with an acute pain in the abdomen. That's it. And when he comes with this pain, he comes and tells me, "Doctor, do something. I have seizure." I immediately tell the patient, "Doctor, Google, listen." So what do I give? I give a painkiller to the patient to decrease the abdominal pain, and that is Pramana. The moment I give Pramana, what happens? The bomb explodes. The tonic phase starts with an ictal cycle, with a versive return, and then the tonic phase happens. And then the post-natal phase came. So the acute abdominal pain, premonitory symptom. Okay? That's the only complaint here. So what do I give? I give a painkiller to the patient to decrease the abdominal pain. And that is Pramana. The moment I give Pramana, what happens? The bomb explodes. The tonic phase starts with an ictal cycle, with a versive return. And then the tonic phase happens. And then the post-natal phase came, wherein the patient is unconscious. Placid. It's not a sharp pose. It's an unconscious placid pose. Post-natal. With urinary incontinence also, that I can show you in the video. Looking at this video, one main comes to my mind. Starts with a control over and think. Yes, correct one. Please hold. So that's an episode of DGCS episode. So let's answer this. Which of the following is best explains about the rectal cry often heard in exercise for the seizure? Pain experience during the seizure onset. No, it's not about pain the patient is shouting. Is it due to sudden contraction of the abdominal muscle? No, it is due to sudden contraction of the intercostal, not the abdominal muscle. Laryngeal irritation caused by hypersalivation is called rectal cry. No. Closed expiration against closed cortex due to tonic phase contraction. That's the correct answer. Okay. Now comes absence seizure. Another very important of the absence seizure. The general age of onset of absence seizure is 4 to 8 years. Outside the books of pediatrics, if you read this topic, it is also referred as Petit Mal epilepsy. Petit Mal epilepsy. The petit as a French word means small, so it occurs in small children. More often. Okay. And how does this actually present? The classical presentation is quite different. It's not a motor movement and all that. It's a totally different story. Like in my house, I play games with my kids also because I've got 2 kids. Just because I've got 2 kids, I'm not a parent, I'm a referee. But I want to play the game with you. That is statue. Okay, screen is safe. The other person is making laugh by some nature, particularly, I'm not going to laugh. I will not respond to the other person. At that moment, I have to be realized. A sale for that. Yes? So at this moment, I'm losing contact or awareness of this happening. If someone plays a medical challenge or a Saturday, that happens in the patient actually. They come close to the behavioral rest or stay over. Then the patient has loss of consciousness. And this loss of consciousness condition is for a very short duration, less than 30 seconds. And of course, on recovery. In the patient, there is mind making, lip smacking, and jolting over the hand. These movements happen on their own. They are known as automatism. Automatism is a generic word that we use for movements which happen on their own automatically. And what are the movements? Are they controlled or movement? No, they are very minor movements. Mind making, lip smacking. After the seizure, of course, there is no harm. And post-natal confusion in patients typically not to be absent. How do you diagnose? Easy. We are going to put liquids that is going to map out the entire brain inside. So clearly, if I look at the brain, this is frontal lobe and this is occipital lobe 4. This is the temporal lobe region and this is the superior lobe. In between, we have the central part also, the center of the brain. Now, if I put an electrode on the frontal region and I record over this for positive charge, why is the temporal lobe and recording what negative charge over this one? It means the region is here. Because this is positive depolarization, this is negative resting. So, EEG as an investigative modality is not only diagnosing a seizure problem, it is also localizing the region. Okay? Now, this is not like comparison that I have. This is not the required here. Look at this. Temporal and occipital, frontal and central and parietal, right and occipital. So, you want to compare them. And then look at the kind of any type of potential difference that you have in the field. We suddenly have silence over here. And these kind of changes are suddenly happen. What kind of changes are these? These changes are quite magnifying shoulder. Look here. You're having a sharp impression like this spike. A smooth contour face. So, we're going to see spiral. So, imagine this kind of a box, one box here. So, this one box that you have is approximately a second time. So, 1 second, 1 box. So, in 1 second, how many spikes are there? In 1 second, there are approximately 3 spikes. And at the same time, how many waves are there? 3 waves. So, there are 3 spikes and 3 waves all the 24 seconds. And you put it up to zero almost 3 waves. So, I'll give you a second. So, in my patient, in the brain. Okay, on both the sides bilateral, there is 2 to 4 hours spiral wave pattern, which is precipitated by a manual that is known as rapid breathing partial condition. Okay, now look at absence seizure. It comes under the category of genitals. Why? Because the EEG changes are on both the sides bilateral. This makes sense. Why do hyperventilate do this? Hyperventilation is more mechanism. If you hyperventilate and breathe rapidly, you are moving the arterial CO to the lungs. So what is decreasing down in your blood is arterial CO to PaCO. If that decreases, then you'll have what? You'll have respiratory necrosis. Respiratory necrosis. If you have this one, then it will stimulate the thalamic neurons which are pH sensitive. Okay. So it's going to stimulate the pH sensitive thalamic neurons. Okay. So what is decreasing down in your blood is arterial CO to PaCO. If that decreases, then you'll have what? You'll have respiratory necrosis. Respiratory necrosis. And if you have this one, then it will stimulate the thalamic neurons which are pH sensitive. Okay. So it's going to stimulate the pH sensitive thalamic neurons, which are going to release what for me? Glutamate. Glutamate is going to open up the channel for calcium onto the neuron cell. And the calcium comes into the neuron cell, then what? A positive charge, and then what? Zero. This body. So understand this concept. Calcium channels and start zero activity. But how are these pH sensitive neurons going to activate? On posterior blood respiratory process. And how can you call respiratory process? By taking up the carbon dioxide. If the CO in the blood rises, it's acidosis. If the CO in the blood comes down, it's alkalosis. But how do you remove the CO and activity? Hyperventilation. I look at the patient. He's a child. And children, if you want, are more playful during one time in the evening time. After school. If they're playing in the evening, they're running more in the evening. They will hyperventilate more in the evening. If they hyperventilate more in the evening, more episodes of absence will occur in the evening time. That's right. The source story in the basic literature was referred as picrolepsy. The word lepsy comes with epilepsy, and picnos is a Greek word, which means extremely frequent during one time in the evening time. In the basic literature was referred as picrolepsy. The word lepsy comes with epilepsy, and picnos is a Greek word, which means extremely frequent and frequent. So all these episodes are put together with extremely frequent in the patient. who was a the patient and another patient of mental malabsorption or abscess. The basically take this word absence from to understand the meaning of this word absence. Because the history given in your pediatric textbook also. If the hyperventilate more in the evening, to activate on first tubular that is respiratory pH sensitive thalamic neurons, which are going to release off what for me? Glutamate. Glutamate is going to open up the channel for calcium onto the neuronal cell. When the calcium comes into the neuronal cell, then what? This already came. So understand this concept. The pH sensitive neurons are going to release out a neurotransmitter glutamate, which is going to open those ligand-gated calcium channels and start the seizure activity. But how are these pH sensitive neurons going to activate on first tubular, that is respiratory alkalosis? And how can you call respiratory alkalosis? By taking out the carbon dioxide. If the CO2 in the blood rises, it's acidosis. If the CO2 in the blood comes down, it's alkalosis. But how do you remove the CO2 by rapid breathing? Hyperventilation. And look at the patient. He's a child. And children, if you know, are more playful during one more engaging, more exposure to absence of than in the evening time. Second, the source story in the literature was referred as epilepsy, the word like absence. But where do we get this word absence from? To understand the meaning of this word absence. Because there is history given in your pediatric textbook also. It's actually the school teacher who explains it to the parents on a parent-teacher meeting in intent. Luckily, in my college days, in medical college there was no meeting. Just my every year there was a college meeting. How do that? Because the professor will ask me, you will ask me, you know. Anyway, so it is a school teacher who tells the parents that the child is not attentive in my class, is not getting good marks. It's a normal thing, you also have to say, I will also say. So now the problem the teacher tells the parents that your child, whenever I ask any question, pointed out, you answer me. He gets panic, and panicking what will do? Hyperventilation. That promotes or provokes what? Absence. And during the episode of absence, the child is taking a stable of that with a loss of consciousness, contact, awareness, whatever. And instead of responding to the teacher, yes or no, I don't know, he just gives a look to the teacher like this, nothing. But the teacher goes here and chases his hand on hand like this, where are you wearing? No response, because he's lost the consciousness awareness. And then the child recovers back conscious. Okay? They're doing like this. I think he's distracting from the moment. Certain motor signs of automatism. Correct? And now the child becomes conscious and he looks around in the class. And everyone in the class is staring at him. He looks at everyone and tells them, what is happening? There is no post-ictal confusion. So prior to the seizure, there was no one, and post-ictal, there is no confusion. There was a brief phase in which the person is physically present, but something mentally absent. We refer this as absence. That is not epilepsy, or older name for epilepsy. Now, student had a question on this topic, he asked me, what you told, I also have it sometimes. In the class, no, you're not suffering with absence either. What you are having is physiological daydreaming. Let me tell you daydreams. Whenever you think about something else, while studying, you go into your own trance phase. At this moment, you cannot complete your dream in 20 seconds. You take more time. So, as some you can say, to fulfill your dreams, arise awake and go for your goal. You cannot sleep over there, just sleep. So, don't worry, all is well. If you are suffering with these episodes, it's physiological daydreaming, but technically it's daydreams, it's absence season. Daydreams part of motivation. So, let me consolidate this into an MCQ. Which are the following is a true one? Typical absence season. Hyperventilation may precipitate episodes more than 4 days duration. Yes. EEG is characterized with serious spike wave on a normal background. Say, right. Remission occurs only in 20% of cases. I don't know. And there's always option C in every MCQ. So you don't have any clue about it. And suddenly comes option D. All of these. Say what? It's the best option. Not it. This will happen in examples. Or of course, one option you're focused and one option is always easy. So must be the answer. See, there's always a Drishyam when you look at a Drishyam. Drishyam movie. They remake Hindi, Drishyam, Malayalam Drishyam. Same concept, 2nd October, 3rd October. And this is another Drishyam pattern. When you go to the option B, which is rated as normal pattern, read it again, a normal pattern. And look at this, this all comes in normal pattern. That means my patient was not having any kind of a electrical problem, and suddenly he has it on hyperventilation. And then again everything goes back to normal. That means everything of this sort, which I explained about, is coming on a normal background, not on an abnormal background. Okay? So option B is not correct. Sure. Option C, remission occurs in 20% of cases. It occurs in only 70%. Up to by the age of 18. So by the age of 18, most of them are having spontaneous remission. That means they don't require any kind of treatment. So, my dear friend, the answer is not D. Atypical absence. Okay? So, of cases. It occurs in only 70%. Up to by the age of 18. So by the age of 18, most of them are having spontaneous remission. That means they don't require any kind of treatment. So, that is mobilization. Imaging shows me structure normality. The IQ is low. EEG shows less than 2.5 hours spike rate. And most importantly, these patients are resistant to the drugs that you use to treat epilepsy. ED, anti-epileptic drugs. Okay. So why are they referred as atypical because in the patient? They don't have those typical pathways. What are the atypical pathways? Second, the sound trouble is of an unknown etiology. That means it's all idiopathic. So please remember the procedure. One is hypoxia. Second is atrophy. And third, some examples like if someone attempts a hanging, brain degeneration myoclonic seizure, metabolic myoclonic seizure. So please remember there are three causes of myoclonic seizure when we see visual myoclonic seizures. But today, in jail, it's often unknown. That means nothing of this sort happens in my patient in spite of the myoclonic seizures as a classical presentation. Let me take you back into this. Hypoxia and atrophy whenever you want to document. You document it by CPR. So there's a large set of patients. Please remember, if a patient comes to you with a myoclonic seizure, of myoclonic seizure, seizure, one is hypoxia, second is atrophy. It's like if someone attempts a anti-mortem suicidal anti, the radiator will come, the person will shake vigorously, and that kind of a jerky movement which is not continuous but intermittent like this, myoclonic, brain degeneration myoclonic seizure, metabolic myoclonic seizure. So please remember, there are three causes of myoclonic seizure when we see patients of myoclonic seizures. But today, in jail, it's often unknown cause. That means nothing of this sort happens in my patient in spite of the myoclonic seizures as a classical presentation. Let me take you back. You documented by CT or MRI, neuroimaging. In my patients of neuroimaging, the CT and MRI is perfectly normal. So there's a large set of patients in a hospital who come for follow-up seizure epilepsy. And then neuroimaging, everything is seen to be normal. They are patients of what? GM. Because in them, in the brain, there is nothing actually wrong causing the myoclonic seizures. They always seem to be wrong. Idiopathic. This means the problem is more severe in the morning hours. That is on awakening when the patient gets up. It is more severe then. And is classically exacerbated by two things. One is fatigue, other one is the alcohol. During the episode, there is no loss of consciousness. And the entire episode is found to be inherited. That means many genes are associated with this. Need a long-term active preventive therapy. Why? I'll give an explanation for this why. Because in these patients, there is no loss of consciousness. And the entire episode is found to be inherited. That means many genes are associated with this trouble. But for treatment purpose, please remember, they usually need a long-term anti-epileptic therapy. Why? These patients GTCS and absence is also the limitation. As we know that majority to be inherited, that means many genes are associated with this trouble. But for treatment purpose, please remember, they usually need a long-term anti-epileptic therapy. Why? And absence is also the limitation. As we know that majority patients of JM have come to our hospital with GTCS, and one track patients with JM have also shown us absence seizure. So there are three presentations of this patient. Majority is GTCS, absence is one third, in between we have the immaculate. Now there was a question based on this. So what is the most common presentation in JB patients? Most common presentation in JB. Everyone has not this answer there. Majority GTCS, another patient. Okay. See, I'll tell you an impact of this that GTCS majority agree, but not everyone. Only 92 of the patients agree, not everyone. Only 92 of the patients. Please remember this fact. Okay. So the most common classical presentation of this patient is always the myoclonic seizure, always. Whenever a baby patient comes with this one, I remember this case. I was an intern, there was a neighbor of mine. He had this problem. Every morning he used to get up, he used to brush his teeth, drink water, or maybe go to glass of milk or breakfast daily. And the moment myoclonic seizure, he used to have this drop attacks. So whatever in the hand used to fall. He went to school, later then myoclonic seizure again happened with bed friend. Okay? So now the parent is disappearing. Since he was adolescent, everyone thought he was under stress. That's why he was on drugs, he was on milk, he was on stuff. It's more of a drama, but a which everyone had given. Until Monday morning in the morning, having my team and the same morning I did Harrison for my good friends. I just imagine. So I looked at my neighbor and I said, sorry, not having any fatal. This is having genuine problem with epilepsy. Epilepsy is still in our country at times. All educated people are still at times. But the moment you declare to die for anyone in your family, you're taking it. I asked my people. Then she very politely said, I don't think so, you know what is there. I said, why? Because you are an intern, that's why. I said, Auntie, Kabir Singh was also intern. Should I become Kabir Singh? Anyway, Auntie told me one thing that, every evening when he's watching TV and playing his game on PlayStation, at that moment he never had that mindfulness. So the point is that the mindfulness levels in jail, Dr. Mabini, what did he do that? But the very next week in the school, the same boy started a mindfulness and was kept updated for such a long time. It went to the face of the disease. So, what was it? So, this is breakfast of mindfulness. Frequent statements went to the school. What is that? Absence. So, what is this? He's a Japan patient who has come to me with many epilepsies. Referred as Japan epilepsy. Wisdom literature I found written to educate the layman about the occurrence of JME or awakening in form of Ayurveda. They are also referred as Kellogg's epilepsy. Nothing to do with Kellogg's. Okay? Actually, Kellogg's I was having that Kellogg's. So just to increase the awareness about it, they just named it in a different way, more catchy word as Kellogg's epilepsy. In case it was because Ola, it is Chola epilepsy. Okay. Measles and epilepsy. The names were not because Kellogg's epilepsy. It's because Ola, it is Chola epilepsy. Okay. Measles and epilepsy. How epilepsy without a patient's brain leads into hypertension. It comes in format of hippocampal sclerosis. So if you locate hippocampus in someone's brain, it's okay. Ola, it is Chola epilepsy. But why do we call this as temporal epilepsy? Because in the patient's brain we seem to have temporal lesion. It comes in format of hippocampal sclerosis. So if you locate hippocampus in someone's brain, it's located on the medial aspect of the brain. And this area is actually sclerosed. It's becoming very small. So this is how you see. There is a smaller temporal lobe to the sclerosis in the hippocampal part. And a psychiatric term which equates to what? Familiarity with unfamiliar surroundings. Familiarity with unfamiliar surroundings. Yeah, very common occurrence in exam when you have gone to the exam without studying. Suddenly you read the question paper and you know nothing. While reading the question paper, you feel you know something. कुछ आता है. Yes, deja vu. Sorry, not deja vu, deja vu. Okay. Now, temporal epilepsy. Now, why did I take up this topic separately? I want to explain this.